Let's go ahead and do item 7.2, presentation of Lake County Behavioral Health Services External Quality Review Organization Report for fiscal year 22-23. And Director Jones and her team are coming up.
All right. Good morning. Johanna, if you could please put up the it's a PDF that has our slides of our presentation. Thank you so much. All right, so I am joined here today by staff, Vanessa Mayer. She is our program manager for compliance, and a lot of other things. Compliance, I just want to give a shout out, is like the unseen work that really makes the whole machine move forward. As your board may be aware, we have many auditing and compliance measures in behavioral health. This is just one of them. So every year we go through the External Quality Review Organization Review. Advance the slide, please, Johanna. Thank you. So, oh, look, I did fancy stuff. Okay, go ahead. Thank you. You could just put them all up. Okay, so what is an EQRO? So EQRO happens every year for every mental health plan. Also, organized delivery system plans also go through EQRO. So when we join into the organized delivery system July 1st, we will be participating in EQRO, and I believe we're going to have a combined...
Two audits.
Yeah, two audits. So EQRO is very valuable to me. I think it's one of the most valuable things that we engage in. It's not an audit, which is kind of unusual. You're very probably familiar with the audit process. Many departments have various audits. We do too. We have many audits in our substance use programs as well as mental health. We have what's called the triennial, which is once every three years, which is changing. I think that they're going to increase perhaps the frequency of those audits. But again, this is not an audit, which means things that they find don't result in a sanction or any type of recoupment. There's not even really a necessarily corrective action plan or anything like that. It's really a benchmark for us to use to say, how are we doing and how can we improve? And it's really meant to be just a tool for that improvement and to give us a system level snapshot of what we're doing. So it's of course codified that we have to do this. The Department of Healthcare Services subcontracts with an independent entity to conduct these. Presently it's Behavioral Health Concepts, and I think that they're holding the contract still.
Yes.
And so there's a lot of different information sources that they review in order to complete this review. One of them is they talk to beneficiaries, which is great, right? And so we get beneficiary feedback through this, and also a lot through our MHSA, which will be coming forward again here soon to give you some findings from that. And our management team review this. We really use it as kind of a roadmap in many ways of where we want to go and how we can improve upon services. Next slide, please. Okay, so this is just a high-level overview comparing year to year. And so this year, we were rated on 26 different items. Those items fall into categories titled access to care, timeliness of care, quality of care, and information systems. So this will show you the number that we partially met and the number that we did not meet between the last two fiscal years. So, you know, it's not the best, it's not the worst, right? There's always room for improvement, and by no means are we unique. Like, this is a pretty, I would say, average and good representation of how counties generally do. It's about what you would expect to see. And so also I'll ask the board if at any time, of course, if you want to ask questions as the slides or you prefer to reserve your questions for the end. And Miss Mary here is obviously our subject matter expert. So we, did better this year and worse this year, depending on the metric. It just shifted. I wouldn't say that there was a huge difference year to year though. Next slide. Perfect. So this is, again, just breaking out some of that information, but in a different way. So last fiscal year, you can also see that we were rated on 26 items. That's the same. We met more of the items this year, 2 more, which is great. So we made some progress, which we love. It is about, if you were going to do math on it, it's about, 69%. So not that that's math we're going to do, but that's what it is. But it is better than last year. We had 1 more not met than we did the year before, but we reduced our partials quite a bit, which is nice. So that's where we saw the biggest improvement, is improving on those areas where we partially met, and somehow we were able to push them over the edge and make them fully met. Next slide, please. So as I broke out before, this is one of the items that we have an area for improvement on, and it's regarded to quality of care and ensuring that timeliness data can be tracked throughout the entire system. What does that mean, the entire system? So as your board is well aware, we contract out for a lot of services. And so we do okay on tracking timeliness within our own department where we control the services, but it's been hard to track that in the entire system of contracted providers. It's a big area for improvement. We're really putting a lot of hope into our new electronic health record, which it is starting to pan out. It had been, as the board is well aware. So we're starting to see some of that work come to fruition. And it is actually really nice to have this semi-statewide electronic health record enterprise, because it is specifically geared to meet those metrics for behavioral health, whereas no other system cared about it, really, just to be honest. EHRs don't have to, but this system is geared for behavioral health. So we're hoping very much that we're going to be able to use this platform to collect that data for all of our contracted and network providers, because they all have access. They have a login and portal to our system. Vanessa, is there anything else that I missed, or would you clarify?
Well, some of our contracted providers actually don't have access to our electronic health record. They prefer to use their own electronic health record. So there's some data integration issues in terms of their timeliness data incorporating into our timeliness data. That was a concern with our previous electronic health care record, and I feel like we have more flexibility with regards to the existing one to implement or incorporate those data sources to be able to report on those timeliness metrics. We're also building up the contractor onboarding and checking in process so that we ensure that there's a thorough communication loop so that we develop those systems and infrastructure to be able to support those timeliness metric reporting mechanisms.
Thank you so much. And you'll see this issues related to technology where it has been insufficient across the board, that's going to be a theme. And so a lot of these solutions are technologically based, and we hope to make that work easier. But also just us coming together and really wrapping around our contracted providers to really be a cohesive network of care is a goal that I've had for a long time, since my program manager days. And so we're starting to see traction and movement on that, in part to innovations in technology. All right, next slide. Okay, so we get beneficiary satisfaction surveys. We're required to issue those every year. They're exactly what they sound like. So beneficiaries of our service can complete a satisfaction survey, and it's one of my favorite pieces of data. So we got a partially met on this because of issues rolling out the survey, essentially. So we're hoping, again, for a technological solution here where we can integrate it more into our electronic health record, but also other outcome data, as the board is well aware, has been notably absent and difficult to track. So actually, finally, I would say the Department of Healthcare Services has recognized this, and as part of CalAIM, I would say overall, they're moving towards more data accountability for counties. So again, we're not unique in this. This is pretty typical of a county experience. So across the board and across the state, there's attention to these outcome metrics, particularly as regards client care. Anything else you'd like to comment on about this, Vanessa?
The Smart Care electronic healthcare record, it we implemented it as a pilot in March of 2023, which seems like a long time ago in retrospect, right? But for a massive electronic health care record that is brand new to California and providing operations for multiple counties in a region with a large subset coming on in July of 2023, was it 20?
23.
Yeah. So there was a lot of impetus behind other infrastructure development to get clients into care, to be able to do the work that needs to be done to get those clients into care. Reporting kind of got a back seat. And so this is an example of one of those reporting components that we didn't get to visualize in December when EQRO came out, or Behavioral Health Concepts came out and completed their EQRO review. I anticipate, based on what I can see in Smart Care, the movement, the traction behind reporting infrastructure, that we will have some of these requirements met, built into our systems, and we'll have what we need by the next EQRO review. We were just a little bit behind in terms of time and infrastructure development for that to be realized in this review.
Thank you, Vanessa. So one dream that I've had that I think is going to become a reality is that aggregate scores for client outcome data, like measures of how symptoms, right? Like any kind of symptoms, there's so many different outcome measures, but the ones that are selected by DHCS, which are now required, we can look at a client's individual chart over time, like a clinician could pull up their chart and it'll show a bar graph of how they're reporting their symptoms. That's like one of my big dreams. So you could actually see, are this person getting better or worse, at least on those reported metrics, as well as aggregate for the department. That would be a dream, and I think we're going to be able to see those. So we look forward to being able to present that type of outcome data here within the next year, I would say. Okay, next slide. Okay, so we have another partially met item here, which is related to quality of care. Again, technology is the theme here. So data archive, as, of course, with the transition into the new electronic health record, where does all the data go from the old one? Well, it so happens that CalMHSA developed a solution that actually we already have a fully executed contract for, and I'm sure the implementation of that work is underway now to archive all of that data in a warehouse that is administered by CalMHSA so that we have it available to us. So again, I'm thinking that work, it's very likely that we'll meet this at this year's EQRO because that solution will have been implemented.
If I might add, while we will meet this, they've decided to remove this from the criteria for next year's as a goal, because it's so vendor heavy in terms of what is needed. They recognize that the vendor is responsible for all of the future actions, that we've already done what we need to do. So while we will be meeting it, we won't get credit for it next time.
I'm going to refrain from any snarky comments. Okay, about this. It's good to see sanity prevail sometimes. I couldn't do it. Okay, next slide. Information systems. So this is a lot of stuff. Vanessa, will you tell us what a 274 form is?
So the 274 is a report that our compliance team completes and submits to our vendor, who then submits to the Department of Healthcare Services on our behalf. It's also closely connected to our provider directories. And what they're looking for is kind of seamless integration between our provider directories and that 274 report, so that our directories are reflecting accurate, on-the-spot recognition of who is able to provide services for our clients, because they're looking at these provider directories to identify who their next provider is going to be. So again, like she mentioned, technology is one of the challenges that we have here in behavioral health, and that's not just local to Lake County, that's actually consistent across the board. So we are working on implementing technology that can kind of breach that gap. They're looking for an connection between the 274 report and the provider directories, and it just doesn't exist yet. We are working on it through our HIE, our Health Information Exchange, but I believe that right now they're working on like a 2-year roadmap, project roadmap for those types of deliverables, and that isn't in this year's project roadmap yet. So they're still developing a lot of this infrastructure, technological infrastructure, but I think we're ahead of the game when it comes to the small counties.
I agree. Thank you. Next slide. Okay. This one is related to the health information exchange. So a health information exchange is a mechanism by which different healthcare entities can communicate real-time data about patients. And so in a perfect world, like let's say we had a client and they were seen in the hospital, even for a non-behavioral health condition, it would, like, when our clinician pulled up their chart in our EHR, it would pop up a flag, like it would notify us that something had happened, which you can understandably see that's important to clinical care. It happens all the time that we don't even know that people have gone to the hospital, right? So this is trying to bridge that gap and make seamless whole person care through a technological solution. It's also a requirement. We're required as part of the Behavioral Health Quality Improvement Program in CalAIM to have a health information exchange. We partially met this. We don't really have a functional health information exchange right now, and that's because initially in the Behavioral Health Quality Improvement Program, we were racing towards a finish line where we had to have an HIE onboarded. So we selected one that was in our region. HIEs are regionalized, and the one that's in our region is called Sac Valley MedShare. So we onboarded with them. As it turns out, they were not able to connect to the interface of our new EHR. Nobody knew that until it was time to do that wizardry of whatever they do behind the scenes, because it's back-end to back-end connections. So moving forward, SmartCare itself and CalAIM HSA has developed their own HIE solution, and that is moving forward. Is there anything else that?
Well, just that we only had one option for our HIE. We only had one HIE that was active within our region, and that was Sac Valley MedShare. The CalMesa SmartCare solution didn't exist at that time. They started development after we signed on with Sac Valley MedShare, or maybe right around the same time. So this option that we are moving towards now didn't exist back then. We did the best decision-making with the options that were available at the time, and unfortunately that didn't really result in something that was viable, and we're pivoting and working with a better solution, we believe, going forward.
All right, next slide.
Also, it didn't meet all interoperability requirements. It only met the portion that was required for BHQIP for a certain specific type of funding. They didn't realize that until later on.
That's a common theme. Okay, so billing. There's been obvious billing issues. We've talked about it extensively here. We're moving forward. Of course, you can see that our billing error rate has been very low. That's because we have a very competent billing team. So now we've had a lot of solutions and fixes in the system where we're starting to see our Medi-Cal payments come in. We anticipate that will continue. And so I don't believe that this is going to come up again. I think we will have resolved that by the time EQRO. And just EQRO takes place typically in December for our county. So we'll expect to have a good outcome on this report in December regarding billing. All right, next slide. So this is a summary of our strengths, which is cool because they do note where you're doing well, and of course there's always areas for improvement. Every year, year after year, our peer support services get rave reviews from our beneficiaries, from the community. One of our staff, what is his phrase? He says that they're the jewel in the crown of behavioral health, and I really do. I think that's such a nice sentiment because they do provide very unique services, and we're also very unique as a county that has right now 4, but we will in the future have 5 again. Most similarly sized counties have none or 1. So we're really ahead of the curve and continues to be an excellent resource for our community. Our timeliness for first offered appointments, like by the time you call and request a service and then you get it, it's better. It's improving. It's always our goal. Like my goal is same day service. I have a dream where you call that day and you get an intake, which I think can become a reality, but of course that process is iterative. So we are making progress there. We're really trying to have a lot of strategy. So one is paid clinical supervision for clinicians, and that helps us grow our own clinicians. And when you have a lot of clinicians, you have less access issues. I mean, it's simple math, right? If you have demand, you have to produce the providers to meet that demand. So that's one strategy. We also contract out all of our psychiatry and a lot of other services. So we have been increasingly relying on contracted providers for those specialty type of services that require either licensure or a doctor, just in an attempt to meet the needs of our community. And so they gave us kudos for that. We actually did quite well in implementing many CalAIM initiatives. We were ahead of the curve, I would say, not just among like-sized counties, but in the state. So we got recognition for that, which is nice. And we do a pretty good job of outreach and engagement with our community partners, particularly with our BIPOC community, with a focus on our Native American tribes and people, and also the unhoused and our Latinx population. So that continues to be a big focus. In fact, our Deputy Director of Clinical Services, April Gambra, she holds office hours every Friday at the Department of Social Services at Big Valley, and we're continuing to build those relationships with underserved and marginalized communities. All right, next slide. Thank you, Johanna. All right, so of course, lots of opportunities for improvement. We did not, performance improvement plans, mental health plans are required to implement performance improvement plans, at least two. One is a clinical, for example, like if I do this type of service, is it going to result in less depression? Is just a general example. Non-clinical means little technological fixes or process fixes that ultimately improve the system. So we had a non-clinical performance improvement plan, but because of the competing demands of the Behavioral Health Quality Improvement Program, which required other PIPs, like there was so many PIPs, and we're not unique in this either. So we're going to get back on track through the BH Quick actually to implement standardized performance improvement plans across our system. And can you remind me, Vanessa, what does QAPI stand for again?
Quality Assessment and Performance Improvement Plan. So it's like a quality improvement work plan that we develop every year. And it kind of goes, it trends over our goals for the last 3 years. So we try to have workable goals that are trackable and measurable, and work towards improving those goals. And those are, that plan is linked on our website. So they're looking for, I think at the time of the review, our compliance team was working at about 50% capacity, and we're a small but mighty crew. So we were feeling that, or suffering from that absence of available bodies to complete that kind of work. So the QAPI work plan got pushed out due to other competing projects. But in terms of going back to the clinical PIP, we contracted with a provider for a full-time clinical compliance staffer. So she can help us develop the clinical PIP this year that we didn't have that kind of resources support last year with. And in terms of the QAPI work plan, we are actively implementing all of the recommendations from the last EQRO into our QAPI work plan, including expanding it to include DMC ODS goals as we move into the organized delivery system in July. So we're really trying to respond to this while also ensuring that it meets all the needs that we'll have in the future.
Thank you, Vanessa. Timeliness data, that's been an issue that's plagued us in a lot of other counties for some time, is that if you don't have a definition, it's hard to track to it. And so we're working on that, and in part it's due to we would ask DHCS for guidance and we would get different answers. And so we're working on that. DHCS has also recognized that they've been inconsistent in their messaging, which is nice. And so I think this year we'll see improvement on that opportunity for improvement in tracking timeliness metrics and have better, more viable data. Some issues with access to informational materials in Spanish. And so that's actually pretty easy to fix. And so I think actually our team has already done a lot of fixes around that and making sure that we have informing materials, that Spanish is our threshold language. So that one is going to look good for us for next year. And lastly, some key informant, they do key informant interviews. Expressed communication, we've had a lot of leadership transition. And also notably, we have a big gap in leadership in our mental health program. We're just closed our latest recruitment for mental health program manager. We have had 2 vacancies vacant since I left as a program manager, I want to say, which is rough. And so I think a lot of the issues that we see on the mental health side are due to the fact that we literally don't have a program manager. And so we're continuing to work on that. And nothing is ever perfect, but it has definitely been a big job. I've increased all staff meetings to monthly. Some of you may have seen it here. This is a very convenient space, actually, and I like it for meetings. So we're doing our best to wrap around our staff and make them feel that they have the ability to communicate with all levels of leadership, and hopefully we will rank better on that next time.
We've also implemented monthly clinical office hours, every 4 weeks, clinical office hours with our staff to give them an opportunity to strategize issues within the system and connect together to share resources and get information and get trained on clinical areas of development. So we are working on improving their availability for communicating with management team through as many measures as possible.
That has been a goal since I, again, was a program manager in 2018-19, was having a better connection between our clinical side and the folks that do services and our bean counters, for lack of, right? And because you got to know what the others are doing, right? Clinicals have to understand what we need from compliance, and compliance has to understand the realities of clinicals. So I think we've made a lot of progress on that this year, and I'm hoping that we'll continue to bridge that gap. And I believe that concludes our presentation. That should be the last slide. Did I get it? Oh, I think so. Yep. All right, thank you so much.
Thank you very much both for your presentation. Are there any questions or comments? Supervisor Pyska.
Are you at 20% vacancy?
I think we're about 19,
Okay,
not to split hairs, but
okay.
mostly in our clinical positions. And then, of course, that vacant program manager position is a big one.
How's recruitment going for that?
For that,
Yeah.
not super great.
Is that hard to fill?
It's hard to fill, I think. I mean, I would.
Or is it
I don't know about the
classified hard to
definition. I
fill?
couldn't. I don't know. I'd have to check on that. But I know we've had at least one failed recruitment
Okay.
in recent memory. It's just tough, you know, and it's you got to have the right person there. Otherwise, you're going to do more harm than good. So I'm very cognizant about that in leadership positions. But it's a rough one.
Okay, thanks.
Any other comments or questions? Supervisor Green?
Just thank you. Very thorough presentation. If you love acronyms, you got to love BH. But thanks to the presentation, I followed along. I followed the bouncing ball as best I could. I don't know how you do it on a daily basis. I would drown in all the acronyms, but what I saw in there for the positive takeaways were very positive. We are ahead of the curve on some things. We have challenges, aka opportunities, as you put it, and I think this just highlights again that we are in a positive trend. And that's no disrespect to the trends we were that preceded, but I was very happy to hear this report.
Thank you.
Thank you again for the presentation. I do have a couple of questions. Sorry, I didn't mean for that to sound final. Number one, highlighting the peer support centers. I think it's continuously being highlighted by these annual reports on the accessibility to the common community that we all belong to. They're spread out around the county, so they're easily accessible to all, and that's greatly appreciated. And I know that we talk in different ways of what kind of different accesses we want there, especially when looking for sheltering and things like that as well. So always appreciated, and good to see the state noticing this as well, and also being the highlight of what we do that others are going to try and copy. It's not just something that we do, it's something that people are looking up to us and saying, how did you get this accomplished for such a small county? The meetings that you said you brought back monthly, I just want to highlight that in the report it talks about the positivity of those meetings. I don't think you hit on that, and I want to make sure to highlight that because I think that is a good morale boost. It's a good way to make your staff feel appreciated for who they're working for and why they're doing the work that they're doing, because it's not easy work, and I'm sure it can get easy to get lost in the weeds of all the work that is being asked of you. Definitely interested in outcomes analysis. I think they've kind of changed their language. I know a couple years ago it said you're making decisions without data. Now they're just saying we need to get outcomes data in order to have a better analysis. And I know that you were saying from individual to department, I'm also very interested in contracts. If we can get outcomes on contracts, then I can really understand which contracts are working and impacting our community members the most and which ones are we not getting the outcomes of. And I know that there's, within each contract, there's a link for reporting. And to me, that we have the scope of service of what we're asking you to do. That can easily, well, not easily, because I think it's difficult to figure out how to analyze outcomes and what we need to be asking for, but that can be part of the contracts of these are the outcomes we're going to be asking you to identify, and then put that into the report that the link leads them to in order for us to be able to obtain that. Just because with all the different contracts we have of varying different costs, being able to really analyze each one and being able to figure out which one is truly providing the benefits we're looking for and which ones are just needed and maybe it's a difficult task to get the outcomes that we need. I think there's explanations that can go along with that.
Yes, and that's been our goal for a long time, and it's a sophistication that will evolve, I hope. But that I would love to see that. Vanessa, I know.
Yeah, I'm like itching to respond to this. Thank you for bringing this up. It's a really important point. But our electronic health record, it's a regional partnership, right? Many other counties have jumped on to Smart Care. And because of that, the impetus behind utilizing that electronic health record is kind of it's growing within our contractor community as well. We're onboarding more of our contractors than ever before in Smart Care, and some are already in there that weren't previously in there, that kind of thing. So we're as they get into Smart Care, we're going to be able to see this utilization in ways that we've never had before. It'll be kind of seamless, just really at our fingertips versus trying to kind of implement their reporting mechanisms into ours. So good point. We did have a basis behind that process. It was convoluted and kind of complicated, but I really, I see a lot of improvement moving forward with regard to Smart Care and our access to that data going forward.
And as one last comment, it's I think the state's goal, and we will see this too, building into contracts funding that's tied to quality outcomes. Is going to be a nice tool. We were ahead of the curve from other counties going through payment reform because we already had our contractors bill us fee for service, like do a service, get paid. That actually wasn't largely the case across the state. So that's a lot of what you heard about counties struggling with payment reform, is that they were just paying like, here's a set, you get this money, and like basically where there was no outcomes tied to it, which we have really not done very many of those. So we're going to continue to refine that, where specific outcomes are tied to perhaps incentive, bonuses as a potential for them to use and grow their staff and do whatever they need to do. And also conversely, looking at, I don't want to say sanctions, but for lack of a better way of putting it, sanctions for not meeting certain quality benchmarks. And that's what we're going to continue to see at the state level, especially with the current governor's administration is very focused on those outcome measures.
Yeah, and it seems similar of a change to what happened with our hospitals, where readmission rates are now being reviewed. We want to take care of people, not continuously see them again and again, or else we're not doing the job that we should be taking care of. And so I think those outcomes will help us better understand how we're doing the work that we're doing. There was some, you were a little too far ahead for the CalAIM, where you started billing accidentally under the CalAIM code. I take all that has been resolved, and those claims that were being rejected between March and July have been resolved and have been paid for?
Yeah, we finally gotten clean up on those.
Okay. And I also feel like I like the idea of the centralization of all of the data and the processes, because now it's also continuity of care, where if they're somewhere else, they can access that level of information. So it's not completely separated treatments that are happening. It's really, you can see the full scope of that individual, that no matter where they are in the county, no matter what facility they're going to. So I look forward to that being fully implemented. But I can't help but parallel with the website for the Affordable Health Care Act, where it just did not function properly at all. And I see this as the same growing pains that the state government is working on to try and get those programs to work. I'm very interested in the potential of updates on some of these things that are works in progress, like the PIPs, the outcomes analysis, and the QAPI, which sounds like a New York way of saying coffee, which is really weird every time I hear it. But I'd love to, maybe 6 months from now, get a review of where we are so that then we can see, rather than waiting annually for the next QERO, because I think part of our job is how can we support you in getting to your destination, more so than just hearing what you've done and what you're attempting to do. So if that's okay with you and if that's okay with the board, I'd love to, at least on the things that you're working on that was identified as work in progress, just to kind of get an idea of where things are and how things are moving.
Yeah, I'd be excited to show you all the quality improvement work plan that we're working on. We'll have that done in the next month or two.
Supervisor Pyska?
Yeah, I mean, I do agree that we should, we talk a lot about getting updates, but it seems like every time you're before us, we're asking for more and more updates, and you're already bringing so many things before us. So we need to make sure that we're not giving you a workload that is not sustainable or keeping you from other things.
Agreed. Agreed.
Happy to come back at the pleasure of the board.
Those are my comments, and I really appreciate the highlighted stuff as well. You guys are doing a fabulous job on a very difficult topic to engage in and take care of. And CAO Parker.
Yes, thank you, Chair. In the same vein of what Supervisor Pyska mentioned, maybe on your monthly updates, you have a small, you can continue doing that, whatever updates you have for these current and ongoing items. Just a thought to save you some time and energy.
And you're mentioning the newsletter?
No, she's good.
No, I'm
Oh,
coming
the
back to your
monthly
board
updates,
about our
gotcha.
money.
Gotcha.
So absolutely would love to highlight things there. Thank you so much for that suggestion.
Yeah.
Perfect. Thank you very much. Supervisor Simon?
Yeah, thank you for the report today, too, but I just want to continue.
Sorry.
Yeah, so that's all right. Make sure to keep working with human resources. We're trying to do everything we can to get those hard-filled positions in there. Department of Social Services, behavioral health, so important because the critical need for the people that are asking for these services. So continue that, have the conversations, think outside of the box if you need to do some of that stuff. And I know this board's worked with different departments and other things to help kind of move that process along in the administration office. So getting those hard-filled positions in these critical needs departments are really important, so just continue that. I know you have our support. I can't speak for the whole board, but myself, and I've seen this board do that.
Thank you.
Thank you so much for your presentation.
Sorry.
Did I open it up for public comment? I have not.
No, you haven't.
So let me do that real quick so that you can get up one last time. Are there any public comments on this item? Please, come on up.
Nurse practitioner at Tribal Health. I'm in primary care, but my question is this division also in charge of emergency services?
We offer crisis services.
I'm just wondering, like, if Tribal Health obviously has their own division of behavioral health. I feel like we're well supported in that aspect. But occasionally I do have patients and families who have instances where a patient may be a harm to theirself or others. And so we need immediate crisis intervention.
Absolutely, we do that. Happy to connect with you, but I'm happy also to broadcast again our mobile crisis benefit. So this is a behavioral health wide benefit. So even people struggling with substance use issues who are feeling at risk of relapse, I'll use this example because it really just shows the flexibility of a benefit, but even children in an argument with their family and it might escalate, and we're trying to prevent hospitalization all the way up to people needing that level of intervention. The phone number is 800-900-2075. It is a 24/7, 365-day-a-year service, and we are here for the community and happy to come out, and I'm happy to connect with you outside as well. Thank you.
Thank you for the comment or question, and I see no further hands in the Zoom room or in the chamber, so I will bring it back and say thank you very much for your presentation, and keep up the good work.
Thank you.